In cardiovascular system, the main symptom will be chest pain. In gastroesophageal reflux disease, it will be burning pain relieved by antacids. And in myocardial infarction, mainly left-sided substernal or epigastric pain. Mainly the radiation is to jaw, hands, shoulders. There will be heaviness, constricting type of pain, and accompanied by abdominal pain, jaw pain, shortness of breath, and sweating. In gastroesophageal reflux disease, the pain will be more in supine position. It is associated with food, burning pain, and it will be relieved by antacids. In aortic dissection, it will be tearing pain, very sudden pain. It radiates to the back, associated with diaphoresis, hypertensive, tachycardia, abnormal or absent peripheral pulses. Ischemic cardiac pain is mainly retrosternal pressure, tightness, constricting, radiating the shoulder, arms, neck or jaw, diaphoresis, sweating, nausea and pallor, as already said. And in pericarditis, it is a typical retrosternal pain only, sometimes pleuritic. And main point, it is relieved on sitting forward, it is positional. In pulmonary embolism, there will be acute respiratory distress, pleural rub, diaphoresis, tachycardia, hypotension, hypoxemia and all. In pneumothorax, pleuritic chest pain, it is also positional, sudden onset, and it is associated with breathlessness, diminished breath sounds, hyperresonance to percussion. In pneumonia, there will be associated with cough, sputum, fever and all. And if it is a musculoskeletal pain, there will be sharp positional pain. Pleuritic, it is aggravated by movements like coughing, twisting the neck or thoracic cage. In aortic dissection, there will be history of hypertension, Marfan syndrome, Ehlers-Danlos syndrome, Turner syndrome, pregnancy, syphilis and all. And in chest X-ray, there will be widening of mediastinum. Transesophageal echo should be done. And the classification mainly two types, Stanford classification, type A and type B. Type A is a common one, mainly seen in the ascending aorta. Surgery is a treatment. Type B is one of the descending aorta. The patient should be stabilized. Pericarditis is the inflammation of the pericardium, and ECG there will be ST elevation and PR depression, PR segment depression, mainly seen as saddle shaped. In acute pericarditis, sharp stabbing central chest pain, and it will be radiating to the shoulder and upper arm. Chest pain may be pleuritic and is often relieved by sitting forward. Aggravation on inspiration, lying flat, cough, swallowing or movement of the trunk. Pericardial friction rub is pathognomonic. Often a rub can be heard even when effusion is present. Non-productive cough, dyspnea and all can be seen. Causes can be viral, Coxsackie virus, bacterial, tuberculosis, uremia also can be there. Causes fibrinous pericarditis. Trauma can also cause pericarditis, and Dressler syndrome mainly after myocardial infarction, post-myocardial infarction, secondary form of pericarditis on the top of cardiac injury, connective tissue disease. And ECG changes we already said, ST elevation and PR segment depression. Now the main features of acute pericarditis, pericardial effusion and cardiac tamponade. Causes we already discussed. Clinical features, in acute pericarditis, it is mainly central pain, aggravation on inspiration, lying flat, and amelioration on sitting forward. There will be pericardial friction rub. And for pericardial effusion, the main symptoms will be dyspnea and increased JVP. And for cardiac tamponade, the main cause will be trauma, and main symptoms mainly Beck's triad, that is increased JVP, decreased BP and muffled heart sound. Beck's triad is increased JVP, decreased BP and muffled heart sound. Now investigations. For acute pericarditis, ECG changes will be there and troponin will be increased. And for pericardial effusion on chest X-ray, there will be globular heart, ECG changes, and low volume QRS complex can be seen on the ECG. For cardiac tamponade, you should check the echo. Treatment, acute pericarditis anesthesia should be given, and for pericardial effusion, pericarditis should be done, and the same for cardiac tamponade. Pulmonary edema, in the chest X-ray, curly B lines, bat wings, hilar shadow and all can be seen. Echo should be done. And then mainly the causes by congestive cardiac failure. The heart will not be able to pump blood efficiently, so the blood will return to the veins and this blood will go to the lungs. The pressure on the blood vessels increases and the fluid will be pushed to the air spaces or the alveoli in the lungs. Main features will be that of desaturation, dyspnea, orthopnea, and on auscultation, crepitations, crackles, and all can be heard. Tachycardia will be there. Treatment can be remembered as MONF, M-O-N-F. Morphine, oxygen should be given, nitrates and furosemide, and the patient should be advised to sit up in the proper position. Pericardial effusion, water bottle sign will be there. Cardiothoracic ratio will be increased more than 0.5. Next is infective endocarditis. When there is a new murmur with fever, infective endocarditis can be suspected. There will be malaise, rigors and all. The first step is to do the blood culture and then echo. Risk factors mainly if there is a previous episode of infective endocarditis, that is the strongest risk factor. Then rheumatic valvular disease, prosthetic valves, congenital heart diseases, and IV drug users and all are at risk. The causative organisms mainly, the most common one is Staph aureus. And in prosthetic valves, people using prosthetic valves, Staph epidermidis should also be there. And Streptococcus viridis in dental procedures. Now the diagnosis, modified Duke's criteria, that is major and minor. Major can be remembered as BE, positive blood culture and positive echo. And the minor can be remembered like 5 pm, mnemonic 5 pm. That is F, fever greater than 38 degrees Celsius. I, immunological phenomena like Osler's knots, road spots, AGN, glomerular nephritis, associated glomerular nephritis. And V, vascular, major emboli, splinter hemorrhage, Janeway lesions and all. E, echo, and P, predisposition, that is IV drug users, cardiac conditions and all, and then microbiological evidence. Splinter hemorrhages are the hemorrhages under nails. Janeway lesions, painless macules that can be seen on palms and anywhere on the soles and all. Road spots are red retinal spots with pale white center. Diagnosis according to the modified Duke's criteria, there should be 2 major or 2 major plus 2 minor or 5 minor to confirm the diagnosis. Valvular diseases. Mitral stenosis. Stenos means closed. So when the mitral valve is closed, blood will not enter the left ventricle. So the pressure in the left atrium will increase and the lungs will become congested. There will be pulmonary hypertension and symptoms of right ventricular failure. Symptoms like dyspnea, orthopnea, hemoptysis, and right ventricular failure features like hepatomegaly, ascites, pulmonary edema, atrial fibrillation, malaf flush will also be there. In mitral stenosis, the first heart sound, that is the S1 will be loud and mid-diastolic murmur with an opening click at the apex. Apex means the left fifth intercostal space in the metaxillary line. On chest X-ray, there will be straightening of the left heart border and the left atrium will be enlarged. ECG, bifid P waves can be seen. It occurs mainly secondary to myocardial infarction and after rheumatic fever and all. And now mitral regurgitation. In mitral regurgitation, pansystolic murmur is heard at the apex. There will be soft S1 and the murmur radiates to the axilla and the P wave will be broad. In mitral stenosis, we said the S1 will be loud. In mitral regurgitation, S1 is soft. Here in the mitral stenosis, it is mid-diastolic murmur and at the apex. In the mitral regurgitation, it is pansystolic murmur at the apex. It radiates to the axilla. In mitral stenosis, it was mid-diastolic murmur and the mitral regurgitation is pansystolic murmur. Both are heard at the apex. In mitral regurgitation, it radiates to the axilla. In mitral regurgitation, it is soft S1. In mitral stenosis, it was loud S1. Now, aortic stenosis is the most common valvular disease. Seen in elderly, it is due to degenerative sclerocalcific changes like calcium deposition. There will be congenital bicuspid aortic valve. We know that aortic valve is tricuspid. In aortic stenosis, there will be congenital bicuspid aortic valve. And in aortic stenosis, it is ejection systolic murmur. It will be heard at the right second intercostal space. It radiates to the carotid artery. Aortic stenosis, ejection systolic murmur at the right second intercostal space and radiates to the carotid artery. And the murmur will be loud at expiration and sitting upright. Features of ASD, angina, syncope, and dyspnea. Now, aortic regurgitation also after rheumatic fever, infective and endocarditis and Marfan syndrome and all. This early diastolic murmur in the right second intercostal space. Now, diastolic murmur is seen in mitral stenosis and aortic regurgitation. In mitral stenosis, there is no radiation and all. In aortic regurgitation, it radiates to the carotid artery. It is early diastolic murmur heard in the right second intercostal space. So, diastolic murmur in mitral stenosis and aortic regurgitation. Now, in mitral regurgitation and aortic stenosis, both have systolic murmur. In mitral regurgitation, it is pansystolic murmur radiating to the axilla. In aortic stenosis, it is ejection systolic murmur radiating to the carotid artery. So, diastolic murmur in mitral stenosis and aortic regurgitation, systolic murmur in mitral regurgitation and aortic stenosis. Loud S1 in mitral stenosis, soft S1 in mitral regurgitation. In mitral regurgitation, it is pansystolic murmur radiating to the axilla. In aortic stenosis, it is ejection systolic murmur radiating to the carotid artery. In aortic regurgitation, it is radiating to the carotid artery. There is diastolic murmur.